most people with time will see their TSH go back to normal. Crucially important because you don't want to start on thyroid hormone, which is often lifelong, unless you qualify that you really need it. Let's discuss if your thyroid diagnosis is correct. And there's some fairly shocking stats that are important for you to understand. I want to share with you because when looking at your TSH and your antibodies, as it pertains, of course, to hypothyroidism and Hashimoto's autoimmunity, there oftentimes is inaccuracy in how the diagnosis is made. So let's start with probably the most compelling data point that I've seen here, a paper by Levels that we've shared on the show before that found 39% of people were on hormone that they needed, whereas 61% of individuals were able to come off thyroid hormone, be tested 6 to 8 weeks later, and found their blood thyroid hormone levels were completely normal. And not only that, but to quote, after stopping levothyroxine, the majority of patients reported feeling better with no significant adverse events mentioned by any subject. So this 61% of individuals in this study by Levels were on hormone they didn't need, came off it, were retested 6 to 8 weeks later. Their blood levels were normal and their symptoms were just fine. In fact, some people felt better. And it's not surprising if you're on a hormone that you don't truly need, you will likely not feel better from it. You will feel worse. Now, this was later corroborated by a follow-up meta-analysis, pinnacle of scientific evidence, and they found something similar, although not quite as alarming. They found 37% of patients maintained normal thyroid function after discontinuing thyroid hormone therapy. Now, I want to be careful to say, I am not advising any action without checking in with your doctor first, but this can function as a prompt to have your diagnosis double checked because as these data support, 37 to 61% of people are on thyroid hormone that they don't need, and it might actually be making you feel worse. Now, as you probably already know, some of the reason why thyroid is often offered up as the potential cause of symptoms is because it affects thyroid hormone every cell of your body, since every cell in your body has a thyroid hormone receptor, including your brain, gastrointestinal motility, reproduction, muscle function, adipose tissue and liver, heart contraction, heart function, blood pressure, kidney and therefore fluid regulation, bone health, and lungs. Because of the many symptoms affected, oftentimes people are a little bit shoehorned into thyroid as being the reason for their symptoms. And what I'm hoping to help you understand with this data and a few other to come is that you should think about getting a second opinion if you're not sure, if you haven't noticed clear improvements from being on thyroid hormone. Now, also, as you likely already know, the pituitary gland and upstream at the hypothalamus monitor levels, and then TSH is a signal from the pituitary to the thyroid to make hormone, and then the gland produces T4. So this is what's assessed, but how we interpret these is very, very important. So this is sort of the take home with how we should be interpreting. Again, don't change anything without speaking with your doctor first, but some doctors have this wrong. So obtaining a second opinion is your prerogative. The cutoff for TSH being flagged high is 4.5. However, being above 4.5 does not mean hypothyroid, does not mean you need medication. This is the tricky sort of pernicious aspect to thyroid. When you go from 4.5 into this region up to 7.10, it's known as either sluggish thyroid colloquially, or more accurately known as subclinical hypothyroid. And this is not a problem for most. And I'll show you evidence in a moment that clearly demonstrates people do not improve symptomatically when they're given thyroid hormone when their TSH is in this range. Now, when you get to above 7 to 10, this transitional zone, this is when you become true hypothyroid, and most people will benefit from treatment, right? But the other really important thing I want to flag for you is test again. If your TSH is in this range between 4.5 to a cutoff of between 7 and 10, if you're in this range, test again after 2 to 3 months because, and I'll share with you a study that finds this in a moment, most people with time will see their TSH go back to normal. Crucially important because you don't want to start on thyroid hormone, which is often lifelong, unless you qualify that you really need it. So this paper published in the American Journal of Medicine, and I'll just quote, patients with thyroid function tests suggesting subclinical hypothyroid or sluggish thyroid do not experience thyroid disease-related symptoms more often than euthyroid subjects, meaning subclinical or sluggish thyroid individuals do not have different symptoms than their euthyroid, normal thyroid peers. So if you are experiencing symptoms, it's coming from somewhere else. And this is the rest of the quote. In subclinical hypothyroidism, clinicians should focus on concomitant diseases rather than expecting symptomatic relief following levothyroxine substitution. Concomitant diseases. This is the key point. This is one of the messages we've been trying to share with you, is that there are usually other areas of the body where the symptoms are coming from. No debate on if you're having symptoms, but the debate is where are the symptoms coming from? And as this study demonstrates, not coming from your thyroid if you have sluggish thyroid. So look to the gut, someone's stress levels, their diet, what have you. But let's outline more data. In this case, a meta-analysis that tested the hypothesis. Well, what if we give sluggish thyroid individuals thyroid hormone? What will happen? Maybe it will help. Quoting, the use of thyroid hormone therapy was not associated with improvements in general quality of life or thyroid-related symptoms. These findings do not support the routine use of thyroid hormone therapy in adults with subclinical or sluggish hypothyroid. Now, key point here. This is a meta-analysis of 21 randomized controlled trials over 2,000 individuals. So the experiment has been run. Placebo versus control. There are 21 of these studies in existence, saying, well, maybe giving people with sluggish thyroid will improve their symptoms. So let's set up an experiment to test this. Let's protect against placebo because we know if you give someone a sugar pill and you tell them it will help them, they will come back and say, yeah, I feel better. So we need the placebo control to verify, does the hormone actually help? Best data point we have, pinnacle of scientific evidence, no benefit. But let's drive this home with one more review paper just from last year, 2022. Generally, treatment, and this is for subclinical hypothyroidism, is not necessary unless TSH exceeds 7 to 10, hence where my diagram comes from. In double-blinded, randomized controlled trials, treatment does not improve symptoms or cognitive function if TSH is less than 10. And they have this wonderful schematic I want to call your attention to, which is so crucially important to understand, which is that a TSH of, let's say, 10 is different if you are 15 years old as compared to if you are 70 years old. There is a natural association, like with many hormones, of a change in said hormone over time. In this case, it is natural and normal to see a drifting upward of TSH over time. So, specifically as they're using here, if you see a TSH of 7 in someone who's elderly, that's not cause for alarm. In fact, some papers have commented this can even harm people because unnecessary use of thyroid hormone can promote osteopenia and osteoporosis. So, zooming out, when someone is not feeling well, they are looking for answers. It's important to use data to drive what answers you seek, because if you operate only underneath emotion, then any hypothesis is up for grabs. So in this case, the experiments have been run and we're seeing that treatment of sluggish thyroid does not lead to betterment. And more good news here, looking at, well, if you do develop sluggish thyroid, what happens over time if nothing is done? And this study found that 75% of individuals saw their sluggish thyroid, their slightly elevated TSH, become normal with time, 75% of the time in a 6-month period. So this is great news. It means that sluggish thyroid is not cause for alarm. So coming back to my table, this is why I say, based upon the data, that subclinical or sluggish thyroid is not a problem for most. A, it doesn't correlate with symptoms. B, thyroid hormone treatment does not improve symptoms. And C, most cases will return to normal on their own without any other remedy. However, even more good news, if you supplement with selenium plus myo-inositol, selenium about 83 grams per day, myo-inositol 600 milligrams per day, what you will see, as this study found, is a furthering of the normalization rate of your TSH. So you can do nothing, and odds are already in your favor that you will improve. However, if you add supplementation with selenium and myo-inositol, the likelihood of your sluggish thyroid returning to normal is even higher. So why I've for so long been trying to help you to understand that we should be very reticent about treatment of sluggish thyroid with thyroid hormone medication. Again, don't change anything without checking with your doctor, because I don't know all of the context of what's going on in your particular case. However, knowing that many doctors are getting this wrong, you should consider a second opinion. Now, the other component to this is thyroid autoimmunity. And the two chief antibodies that are assessed are thyroglobulin and thyroid peroxidase, telling you if you have thyroid autoimmunity. So let's unpack this a little bit. Now, in this observational study of 16,000 patients, they found, and I will quote, no significant association between thyroglobulin antibody levels and hypothyroidism. What this tells us is that thyroglobulin antibodies suffer from likely a high level of false positives, or if it's a true positive, it doesn't seem to negatively impact thyroid hormone function because there's no correlation between thyroglobulin antibody positivity and hypothyroidism. TPO is an antibody that correlates. However, there is a current issue of overzealousness regarding interpretation. I've often said that if someone has a fasting blood glucose of 103, we don't go, whoop, diabetes, right? So not all levels of fasting blood glucose are interpreted the same. If you're 163, that's different than being 103. I don't know why this same thing is not commonplace with interpretation of TPO antibodies, but this one wonderful study found that if you had levels of TPO above 500, you had a risk of progressing to hypothyroid. Because remember that Hashimoto's and hypothyroid are separate things. Hashimoto's increases the risk of hypothyroid, doesn't guarantee it, but they're not the same. So this is the key point. Above 500 for TPO, there was a risk. So we could call this high. Below 500 was considered control, and there was no increased risk of developing hypothyroidism. This is hugely important to understand. Many providers are telling people we've got to treat your thyroid antibodies, TPO, down to 0. And this could not, well, I shouldn't say it couldn't be further from the truth, but the best data that we have to date does not support that. And then normal, according to the labs, is below 35. This is crucial. Now, the other thing I want to point out is TPO antibodies alone are not fully diagnostic. And we can look at a few data sets here. NHANES, a meta-analysis, and then, so let me sort of frame this for you. What you're seeing here is the prevalence of Hashimoto's. And when looking at just TPO antibodies, as was done in this NHANES data set, you see an 11% occurrence rate or prevalence rate of Hashimoto's. However, knowing that antibodies do not tell you what's going on in the target tissue per se, some studies have correlated the antibody findings along with ultrasound to see if there is resultant inflammation in the gland. And when you look at TPO plus ultrasound confirming, you go from an 11% prevalence rate of Hashimoto's down to a 5.3% prevalence rate. So, coming back to this slide, perhaps part of the reason why below 500 was considered acceptable was because there's not a super tight agreement between TPO and thyroid gland damage, therefore prediction of becoming hypothyroid. So the take home here is that thyroglobulin antibodies don't seem to correlate with thyroid autoimmunity. TPO antibodies under 500, we can say, is a clinical win, and you don't need to treat antibodies to zero. I do think TPO is a good early screening tool. However, the balance with interpretation is very important because in our office, we have seen many people who are on unnecessary dietary and supplemental protocols because they have a TPO that's lingering in the 100s, 200s, 300s, 400s. So we want to be progressive, but we don't want to be overzealous. And that's what I'm hoping is becoming apparent here. So to put it all together and just taking a step back from this, some of integrative medicine has this right and some of conventional medicine has this right. So this sort of constellation of interpretations is really a derivative of what I feel to be the best data from both camps, because depending on what camp you're in, you may be saying, that's different than what I've heard. That's different than what I've been told. And this is because I think integrative medicine and functional medicine has some things here wrong and conventional medicine has some things here right. And we should just call these things balls and strikes, meaning if it's accurate, we'll do it. And if it's something that seems more dogmatic, more dissonant from the data, then we're not going to do it. So to bring it all home, check your TSH. If under 7 to 10 and you're on hormone, consider getting a second opinion. Now, the key point here is check your TSH from before you started on thyroid hormone. Once you're on hormone, you can't assess this, right? You can assess if your hormone levels are, if your medication dose is high enough to get you to the normal range, but you can't assess your endogenous output, right? So if you can get the labs from before you were diagnosed and those labs before you started on hormone showed a TSH between 7 and 10 and you're now on hormone, consider getting a second opinion. Said another way, if you were a little bit unclear in your diagnosis, get a second opinion. And consider using selenium and myoinositol if your TSH is between 7 and 10, because like we talked about, that can improve the odds of getting back to normal, even though being in that range isn't necessarily a cause for intervention. Check your TPO antibodies. If under 500, consider this a clinical win and your hypothyroid risk is low. You can still consider improving your diet and getting more dietary selenium and myoinositol, supplementing with vitamin D with selenium and with myoinositol, but these things are not urgent. They're not necessarily needed. And the final point here, even though this may expose me to some slings and arrows, if you were diagnosed by an integrative doctor, someone who is not practicing in the conventional model, then I would consider getting a second opinion. And this is not to disparage any provider. I think we're all trying to help. Unfortunately, in the camp of integrative functional alternative medicine, the TSH is rampantly misinterpreted and the TPO is also very commonly misinterpreted. On the other side of the coin, oftentimes a conventional provider might be a little bit lackluster in terms of dietary and nutritional recommendations for your thyroid health. However, they're not incorrectly diagnosing the TSH and the TPO unless they're conventional, but now practicing in an integrative anti-aging sort of model. So just a few things here to be aware of. And remember that if you've been given an unclear diagnosis, if you feel there's been a little bit of dogma, fear, or overzealousness in your provider's perspective, it's your prerogative to obtain a second opinion. And remember how compelling these data are, showing the overuse of thyroid hormone and the overinterpretation of the thyroid autoimmunity. And all this matters, coming back to that earlier quote, because you want to focus on the concomitant issues that might be driving your symptoms, because the most important thing is that you achieve symptomatic resolution and don't suffer needlessly. So if thyroid's not implicated, let's stop traversing down an avenue of therapy and look toward where the issues might be coming from.